Hello, everyone. Thank you for this opportunity to talk about my PhD project in progress. I'm Xianglin Zhao from McGill University, and I'm supervised by Dr. Xianglin, and I will use a Bayesian model averaging method to identify patient subgroups with treatment effect heterogeneity. First, I will use some example to introduce the background of this project. So response heterogeneity exists in many different kinds of clinical trials. For example, in multi-regional clinical trials, it is recommended to estimate different treatment effects for different region in the study. Another famous example is basket trial. Subjects with same mutation but different types of cancer are included in a study and receive common treatments. And we all know that the common treatment, the response of these common treatments might be different for different cancer histologies. So what are the properties of the data generated by this kind of study? Well, first, population can be divided into subgroups. And second, investigated regimen might not be effective in all subgroups. And also the level of response might differ between subgroups. One key goal of such study is that we want to identify for which subgroups the treatment is effective. The effectiveness is defined as a treatment rate greater than some threshold we decide. So the aim of my project is to identify patient subgroups with heterogeneity in APTs with factorial design. One motivation of this project is that for rheumatoid arthritis, combined therapies from various domains are effective in some subgroups. Subgroups with different levels of effectiveness. And we want to identify the predictors determining the effectiveness of combined therapies. One example is the REMAP-CAP study introduced earlier today. They explored 240 potential regimens with a factorial design on different patient strata. And this picture shows a 2x2 factorial design. Say if we want to explore the combination of like two biologics and two different nutrition supplements. And these two regimens are tested on three biomarker groups shown in different shapes. And the response rates are shown as the proportion of colored shapes. So in here, if we don't assume any, don't allow for any information sharing, we will have 6 different response rates to estimate, which is not very effective. So to reduce the parameter, one natural thought is that if the response of two subgroups are similar enough, we want to pull them together and estimate a common response rate. Well, before going to the factorial design, we can look at a simpler situation where we only have one available treatment on 3 biomarker groups. The full model can be built as a logistic regression with one 3-level categorical variable, which is the biomarker group. So if we choose k equals 1 as our reference level, the model will look like this. Yeah. Here, if we treat the subgroups separately, the power might be low. So we want to allow for information sharing between subgroups. And meanwhile, we want to account for the uncertainty about our information sharing model. Dr. Sayota and his colleagues proposed Bayesian model averaging for basket trials. This method synthesizes information from different models. And also this method is compatible with adaptive design, which means that the basket can be closed due to futility or efficacy. And then let's look at the model space. When k equals 3, which means that we have 3 biomarker groups, the complete model space contains 5 models, and each model partitions the population into exchangeable sets. And for each set, we estimate 1 common response rate. So this is the full model where we assume no exchangeability without any pooling, or we can pull 2 of them together or all 3 of them together. So how do we parameterize that? We can add restrictions to the full model. So this is our full model, and these are the candidate restrictions. Say if we select 0 restrictions from that, this will be our full model, assuming no exchangeability, and we only have 1 possible way to select from that. Otherwise, if we select 1 restrictions from that, that will be the reduced model, pulling 2 of the subgroups together. And here we have 3 possible ways to select. And if we select 2 restrictions, that will be our minimal reduced model, pulling all 3 subgroups together, assuming full exchangeability. And here we only have 1 possible way to select. In total, this will be our 5 model in the model space as introduced before. Here, I want to introduce the model averaging logic under the Bayesian framework. We can assign our prior belief in a model space. And after seeing the data, this prior could be updated, which is the posterior in a model space. So each of this model will return a posterior probability of efficiency. And our final estimation of this posterior probability will be a weighted average of all this model. So when we come to 1 by 2 regimen, we can still use logistic regression, but this time we will have 2 categorical variables, regimen and biomarker. And we want to include the main effect and interaction term to model the 6 different response rates. And here is the 2 by 2 regimen. Still, we use logistic regression, but this time 3 categorical variables. And there are 2-way and 3-way interactions. We use this model. We use it. This is the full model, including like 12 response rates. Oh, thank you. I got it. Thank you so much. Okay, let's look at the model space. And each regimen cell will have 5 possible partitioning configurations, just as we discussed in the 1 regimen example. And the complete model space contains 5 to 4 models. So how do we parameterize that? Still, we can add a full model with restrictions, but this time we will have 4 groups of candidate restrictions. In each group, we can select 0 or 1 or 2 restrictions, and that will be 5 possible ways. And after selecting from all 4 groups, we will generate the complete model space. Okay, complete model space with 5 to 4 models. And this is 3 possible models from that. This is a full model, and these 2 are the reduced model, pulling some of the subgroups together. I will briefly talk about the challenges and plans of this project. BMA method was originally proposed for variable selection, and now is proposed to borrow information dynamically from subgroups with treatment heterogeneity. And this method performed well for binary and continuous outcomes. There are 2 advantages that were utilized in previous studies. One is they have conjugate priors, which means that they can calculate the posterior probability for each model. And second is that they averaged they exhausted the complete model space and averaged between them. And when we want to expand the method to factorial platform trials, we will not have conjugate prior anymore, which means that we can only estimate instead of calculate. And also the factorial structure will increase the number of parameters to be estimated. And also it will be impossible to explore the complete model space. So about the first challenge, I've already used MCMC to estimate one factorial model without any averaging. And the next step will be to reduce the computational burden. I will use some specialized MCMC to sample from, model space. Especially when we have uncertainty about the dimension of parameter space. So yeah, thank you for your attention and patience. I'm sorry for my voice. And these are my references. Yeah, I'm glad to take any questions and suggestions. Thank you very much.